We will go ahead and kick off the meeting. For those of you who don't know me, my name is Jackie Rao, and I'm the program manager for the Michigan Collaborative for Type 2 Diabetes. We are so excited and lucky to have Rina Hisamatsu, who is our lead Mcttd dietitian, now onboarded to the team and to take over to begin doing these monthly calls, which we hope are helpful to you and that we want to refine over time to meet your needs exactly. So what we're going to be doing today is Rina's prepared a short presentation, about 15-20 minutes max, that she's going to go through just to introduce herself, go over some high-level low-carb diet information that should be familiar to most, but it'll be a good refresher, get everyone on the same page. We did ask for questions to be submitted ahead of time, so we got a couple of those in that we'll go over, and then we will open it up to all attendees and any questions that you have. So I'm going to hand it over to you, Rina.
Thank you so much, Jackie. Hello, everybody. So let me just share my screen real quick and we can get started on the presentation. All right, so hopefully everybody can see my presentation slide. Please let me know if that is not showing up. All righty, everybody. So welcome to the first session of Mcttd's Q&A. My name is Rina Hisamatsu. Oops, excuse me there. All right, so here's an overview of the topics that we'll be covering today. So I would love to provide a brief introduction today to go through some of the general statistics of diabetes within Michigan, Mcttd's core goals, as well as some of the fundamentals of the low carbohydrate meal plan. I'm hoping to use the rest of the time today, as Jackie had mentioned, as sort of an open forum to address some of the questions from our audience, as well as some of the questions that have been submitted prior to our session today. All right, so a short disclaimer here before we get going. So I wanted to just formally put in writing that so the low and very low carbohydrate meal plans should not be used in patients on an SGLT2 inhibitor. Patients who are on an SGLT2 inhibitor should at least have 130 grams of carbohydrates in a day. Patients who are interested to follow a lower carbohydrate meal plan should discuss with their provider, and the SGLT2 inhibitor should be discontinued if the patients are on this medication. Furthermore, other medications such as insulin, sulfonylureas, and blood pressure medications may need to be adjusted accordingly at the start of the low carbohydrate meal plan to avoid complications such as hypoglycemia or hypotension. All right, so once again, my name is Rina. I'm the health educator here for Mcttd. A little bit of a quick bio about myself. So my educational background is in public health and dietetics. I'm passionate about improving the health of individuals and communities through evidence-based, patient-centered care. I have experience working in several local and global settings, including outpatient nutrition counseling, some research and community nutrition as well. During my time at Michigan Medicine, I have been involved in primary care as well as some specialty clinics, counseling on the low carbohydrate meal plan. So I'm excited to join as part of the team of Mcttd Collaborative as a health educator to support their core goals. All righty, so we may all be aware by now that the burden of diabetes in America has reached epidemic proportions. Over 34 million Americans are living with diabetes today. When we look at the statistics within Michigan itself, approximately 11.5% of the population has diabetes, and many more remain undiagnosed. Furthermore, over 2.7 million people in Michigan are living with pre-diabetes. With these alarming numbers continuing to emerge, it is really paramount that we identify strategies to prevent and reverse the trajectory of this disease. Now, in the following slides, I'd like to show some additional statistics from the CDC to really demonstrate the rise in the prevalence of diabetes and obesity among adults. These statistics represent data from 2004 to 2019. A note of importance here is that these statistics show the prevalence of diabetes as combined type 1 and type 2, and they are not differentiated here in these statistics. However, it needs to be acknowledged that type 1 and type 2 diabetes are two separate disease states, and treatment considerations should be differentiated accordingly. So as you can see from these heat maps, the following heat maps, the time between 2004 and 2019 has seen a dramatic increase in the prevalence of both diabetes and obesity. So I went a little too fast here, but 2004, 2009, 2014, and 2019. As you can see, it gradually increases in the prevalence. The other reason we're focusing on type 2 diabetes now is that over the last 5 to 10 years, we have new research studies and new treatment options that have not yet been fully implemented in primary care. In the past, we thought of diabetes as largely familial, and instead of preventing the disease, we try to diagnose it early so we can start medication, improve control and management of diabetes. The current paradigm of type 2 diabetes standard of care is centered around the treatment of the disease to slow its progression and to reduce complications associated with it. However, the MCTD initiative aims to shift that paradigm of diabetes care through innovative strategies that are targeted at preventing and reversing the progression. Now, the following slides, I want to explain the 3 core quality improvement goals for MCTD, which are to prescribe the use of new type 2 diabetic medications that are more effective in glycemic control. These include the GLP-1 receptor agonists and SGLT2 inhibitors, expanding the use of continuous glucose monitors to improve blood glucose management, and supporting the lower carbohydrate meal plan as an effective means of blood sugar control. The focus for today is to start a conversation on how best we can support the lower carbohydrate meal plans as an effective means of blood sugar control. Although type 2 diabetes is characterized by chronic hyperglycemia, the current literature suggests that the underlying cause of type 2 diabetes is really rooted in chronic hyperinsulinemia and insulin resistance, typically resulting from a prolonged period of increased energy intake, often leading to obesity. Furthermore, we know that insulin is an anabolic hormone that promotes fat storage not only in the pancreas and the liver, but also visceral fat as well. Therefore, this therapeutic carbohydrate restriction or low carbohydrate meal plans offers this opportunity to halt that cycle of hyperinsulinemia and insulin resistance to treat the root of type 2 diabetes. All right, next I wanted to show a graph that depicts an example of a case where an individual is treating diabetes with traditional insulin therapy versus the combination of the 3 initiatives within MCTD. So that includes using a low carbohydrate meal plan, new anti-hyperglycemic medication, and CGM use. Both of these therapies do show an improvement in their hemoglobin A1C over the course of 12 months. However, the first example leads to increased insulin use and dosage and subsequent weight gain, while the other reduces insulin use and promotes weight loss, among other benefits. So for individuals with type 2 diabetes who are not meeting their glycemic targets, or for individuals whom reducing these anti-hyperglycemic medication is a priority to them, implementing the lower carbohydrate meal plan could be a viable approach for them. Now, what exactly is a low carbohydrate eating pattern? Now, the definition of the low carbohydrate eating pattern has many variations. Currently, there is no consensus on the language that's used to define the variations of the low carbohydrate meal plans. However, there have been recommendations for the consistency of approach, and the most widely used guidelines found in the literature today are as follows. So the very low carbohydrate meal plan is generally less than 10% of the total caloric intake, and that generally reflects about less than 50 grams of total carbohydrates a day. The low carbohydrate meal plan is less than 26% of total caloric intake. Generally, that is about less than 130 grams of total carbohydrates. The moderate carbohydrate meal plan is between 26 to 45% of caloric intake, and that's generally 130 to 225 grams of carbohydrates. And the more standard high carbohydrate meal plans are oftentimes greater than 45% or 225 grams of carbohydrates a day. By definition, any dietary pattern that consists of less than 130 grams of carbohydrates a day is considered a low carbohydrate meal plan. So the low carbohydrate meal plan has many positive outcomes based on the current literature. This includes reduction in hemoglobin A1C, reduction in both anti-hyperglycemic and antihypertensive medication, weight loss, reduction in improvements in overall lipid panel, including reduced triglycerides and improvements in HDL cholesterol. In addition, reduced hunger and cravings is another outcome that's often reported in individuals who follow the low carbohydrate meal plan. Potential reasons for this could include changes in hunger hormones, such as reduction in ghrelin, as well as an overall improvement in the quality of foods when an individual adopts a lower carbohydrate meal plan. These include whole food protein sources, non-starchy vegetables, and limiting refined carbohydrates that are often quickly digested and absorbed. Now, it is really important to recognize that the low carbohydrate eating pattern is not a one-size-fits-all approach. Before recommending a low carbohydrate meal plan to your patient, it's really important to consider factors such as their personal preferences, food preferences, personal goals, their previous experience, if any, with the low carbohydrate meal plan, as well as their medical history. So assessing their desire, their level of comfort, and assessing their level of support is also is key to ensuring success in patient safety. Now, I often get asked about the difference between nutritional ketosis and ketoacidosis. So this may be a review for most of you, but I just wanted to go through these couple of slides. Now, nutritional ketosis we know is a normal metabolic state in which your body uses fats and ketones in the form of beta-hydroxybutyrate, acetoacetate, acetone, rather than glucose as the primary energy source for your body. When you're following a very low carbohydrate meal plan, so that's less than 50 grams of carbohydrates a day, you're activating this alternative energy pathway once you've depleted your your body's glycogen stores. During nutritional ketosis, ketones are made in the liver from fat stores as well as dietary fat. Your liver also produces ketones on a regular basis in small amounts, even when you're on a higher carbohydrate meal plan, such as when you're fasting. Once the level of ketones in your blood has reached a certain threshold, you are then considered to be in nutritional ketosis. Typically, that threshold is about 0.5 millimolar per liter of beta-hydroxybutyrate. It's important to distinguish between nutritional ketosis and ketoacidosis. Now, ketoacidosis, as we know, is a medical emergency that needs prompt and immediate treatment. It typically occurs in individuals with type 1 diabetes if they're not getting enough insulin to meet their needs. Generally, in diabetic ketoacidosis, or DKA, blood sugars and ketone levels rise to dangerous levels, often greater than 10 millimolar per liter, which leads to disruptions in the delicate pH, the blood's pH balance. However, when you're in nutritional ketosis, it's very rare that blood ketone levels go above 5 millimole per liter. Now, once again, an important word of caution is that low and very low carbohydrate eating patterns should not be used for individuals who are taking SGLT2 inhibitors due to the risk of euglycemic DKA. In general, patients on an SGLT2 inhibitor should at least have 130 grams of carbohydrates a day. And the SGLT2 inhibitor should be discontinued if the patient prefers to follow a lower carbohydrate meal plan. All right, so now let's shift gears towards the meal plan itself. What do individuals eat exactly on a low carbohydrate meal plan? Well, a well-formulated low carbohydrate meal plan will prioritize protein intake, will include an abundance of non-starchy vegetables, and some fats for satiety. As you can see to your left, these are some examples of foods that we encourage on a low carbohydrate meal plan. These include protein sources like beef, poultry, fish, seafood, non-starchy vegetables like spinach, cruciferous vegetables, mushrooms, zucchini, and healthy fats like avocado, eggs, etc. Additionally, all low carbohydrate eating patterns will de-emphasize the consumption of most starchy foods like potatoes, rice, pasta, bread, sugary foods like cookies, cakes, sugar-sweetened beverages, as well as refined carbohydrates such as refined cereals or flour products. Here, what I've done is we've adapted the USDA's My Plate Guide to reflect generally an approach to creating a balanced low carbohydrate or very low carbohydrate meal. This is a simple guideline showing the 3-step and the 4-step for creating a balanced low carbohydrate meal. So for individuals who are following the very low carbohydrate meal plan, which is less than 50 grams of carbohydrates a day, we encourage their plate to prioritize protein intake from quality sources, abundance of non-starchy vegetables, and some fats. For the low carbohydrate meal plan, that's less than 130 grams of carbohydrates a day, we add that additional 4th step with the addition of some complex carbohydrates to their meal. So these sources of complex carbohydrates can come from foods such as beans, lentils, legumes, whole grains such as quinoa, oats, barley, farro, winter squash like spaghetti squash or butternut squash, as well as some fruit. Now, in the last remaining slides, I would like to briefly discuss some ideas around alternatives to high carbohydrate foods. So a high carbohydrate meal can be simply transformed into a low carbohydrate meal by omitting the starchy component, such as the bread, rice, pasta. However, you may also consider replacing that starch component with an alternative using non-starchy vegetables like cauliflower or zucchini, as well as some other examples listed here on the slide. So these low carbohydrate alternatives are a delicious and nutritious way to make a satisfying meal that's also packed with dietary fiber. If you're feeling a sweet tooth, there are some examples that I put down below for some low carbohydrate desserts, including things such as berries with whipped cream, dark chocolate, which we often recommend 80% or greater, sugar-free Jell-O cup, or you may even experiment with low carbohydrate desserts such as coconut chia pudding. Now, these are some of the examples of meals using some of the low carbohydrate alternatives. As you can see here, making spaghetti and meatballs using zucchini noodles, or making mashed potatoes with cauliflower. And then on the right-hand side, you can see cauliflower fried rice as an example as well. So with these, with a little bit of creativity, you can recreate some of your favorite meals to make them low carb. All right, so last but not least, I wanted to wrap up the presentation today with a short, and share a short survey with you. So this survey is, it's really a short 3-question survey, and what we're trying to find here is to figure out what exactly, what are the areas of support that you all would like to discuss in future sessions going forward. What are some of the challenges that you're facing with low carbohydrate counseling with your patients, and any other comments we would love to hear in terms of feedback. So we have provided both the link, we'll provide the link in the chat, or you can also scan the QR code here to access the survey. All right, and with that, that is the end of my presentation. Thank you all so much. Let's open up the floor for the next segment of this presentation.
Sounds good. And Rena, before I pull up the pre-submitted questions, we did get one that was during your presentation that was messaged to me. It was, where are the carb goals information taken from in the literature? You mentioned evidence-based medicine and mixed info in the literature, no consensus. So curious where that resource was from.
Yeah, good question. So the current guidelines, let me hold on, stop sharing for just a second here. Okay, so the current guidelines for the carbohydrate allotments, again, this is a new area, and we're consistently learning and analyzing the data that's coming in. So there are some variations in terms of the definition of low carb and very low carb. However, the most widely used carbohydrate allotments are based on the numbers that I had shared with you earlier in the slides. And there are a few resources actually that I can share with you after the end of the presentation today, with the current, which is where I have adapted those guidelines from.
Okay, so are you ready for me to go ahead and share these pre-submitted ones, Rena? Mm-hmm.
Oh yes, that would be great.
Perfect. So we'll go through the questions that people had submitted. We sent out a poll to everyone who had registered for this meeting and said, if you already know what you'd like to ask, please feel free to go ahead and share that with us beforehand. So that's what we're looking at here. And so Rena's taken a look at these questions already, and we'll go through her responses. So the first one was around teaching materials, and what was submitted was that this practice had been using the Cornerstone for Care's meal planning and carb counting for their diabetes teaching. It's being discontinued. So what other materials do offices or people use with their diabetes teaching, ideally like an all-inclusive book?
Mm-hmm. So that's a really great question. So the current type of resources that I would point towards include, actually, I made an additional slide at the end of my PowerPoint with additional resources. So that includes the Mcttd resource library. So we have some preliminary information and handouts that can be utilized for both teaching education, as well as for providers if they would like to review medication management, tracking tools, and nutrition resources as well. Furthermore, the ADA has also come out with a recent guideline for practitioners on the low carbohydrate and very low carbohydrate eating patterns. So let me actually put that in the link as well.
You want me to pull up your slide that you were referencing, Rena? I would be happy to do so. Mm-hmm.
Yeah, would you mind, Jackie? That would be great. Thank you.
Not at all. Let me just copy it over right from your presentation. Give me just 1 second. Okay. So this is the slide that Rena was referencing. It is in the slides that were sent out to everyone in the initial part of this meeting. And it looks like Rena has linked exactly to where you can access these either on Amazon or on the sites that they're hosted at.
Yeah, so the second resource that I just mentioned from the ADA is also linked to their website, so you can take a look at that resource. Additionally, these are some additional resources around low carbohydrate eating. For example, there's a book on the art and science of low carbohydrate meal plans. That's also a good resource, as well as low carbohydrate or low carb for any budget as well. Going forward, Mcttd, we are working towards creating more additional nutrition resources for patients that are patient-facing as well as provider-facing. So we're excited to work on those, and they will be available going forward as well.
Okay, perfect. Thank you so much, Rena. The next question was around terminology. Are there any plans to consider a different terminology than low-carb diet? Low-carb diet is an umbrella term that encompasses different versions. Nowadays, low-carb is synonymous with keto. I feel there will continue to be an effort on the collaborative to distinguish the two, so there isn't a perception of promoting keto.
Right, that's a really great question. So the term diet is often depicted as sort of a temporary change in our eating habits to promote a certain outcome. However, we encourage not to use the term low carb diets, but rather a meal plan or a lifestyle. So to be more inclusive to the idea that low carbohydrate meal plans are more of a long-term lifestyle change than a short-term solution. As we had discussed today, you know, there's some variation in the definition of low carbohydrate meal plans, ranging from very low carbohydrate to low carb to moderate carb to high carb. So as we continue to collect data and the literature, hopefully we will come up with a standardized consensus on what those exact carbohydrate allotments will look like going forward as well. And to answer the second part of the question, any specific plan to create nutrition documents? Absolutely. So we're working on developing some, you know, patient-facing materials and provider-facing materials, celebrating. Hopefully, we'll also create some that celebrates the different diversity of cultures that we have across Michigan. So it's good to know that is an area that is much needed. So we will definitely put that into our priority list when we develop these handouts.
Yeah, sorry about that. I separated that question into two separate ones, and this was what Rena was just answering. Is there a plan to create nutrition documents specific to different food cultures, allowing for appropriate food swaps and an alternative that is more inclusive? And to echo what Rena said, this is definitely something that we want to do, and we want to be able to provide resources that are a little bit more broad and inclusive to that point. So it is something that we'll be focusing on.
If any of you in the audience have specific patient populations that you work with, and you would like those populations to be reflected in terms of the materials, please let us know either in the chat or in the survey going forward.
Okay, great. And the next question was about sweet low-carb snacks. Do you have any suggestions or recommendations or resources for sweet low-carb snacks for patients? Patients are always looking for alternatives to ice cream, cupcakes, and desserts in general. Thanks. And I did, Rena, pull over this slide from your other presentation that touched on this a bit.
Thank you, Jackie. Yeah, so I just put together a quick list of some savory low-carbohydrate snacks and sweet low-carbohydrate snacks. So this is not an exhaustive list, but these are some common ones that I typically counsel offer with my patients. When it comes to sweets, as you can see here, these are typically having berries is one of those exceptions in terms of fruits that are encouraged on a low carbohydrate meal plan. And berries pair really well with something like whipped cream or even coconut cream. If they wanted to sweeten it, they have the option of adding in some non-nutritive sweetener, whether that's stevia or monk fruit are the two that I typically recommend. You may also be interested in making a Greek yogurt parfait, again with some berries on top, chia pudding using coconut cream and some chia seeds, sugar-free jello, dark chocolate. Avocado chocolate mousse is also a really delicious recipe. It really just requires a few ingredients, an avocado, some cocoa powder, a little bit of vanilla, a little bit of a non-nutritive or sugar substitute for sweetness, and then a little bit of milk to get it rolling. Generally, I recommend something like a coconut milk or an almond milk for more neutral flavor. And yeah, so those are some ideas. And a smoothie is also a good idea, a low carbohydrate smoothie that's focused more on the protein from Greek yogurt and some berries, adding the coconut milk or almond milk and ice cubes and stevia to taste. Yep.
Rena, to add on to that, and this is just like a question that my head as you're going through these answers. So I've like seen at the grocery store, for example, like keto ice cream and things like that. Is that something that you like would recommend or do recommend to patients, acknowledging that it's much more expensive and kind of niche than your kind of standard ice cream? So there's always the cost element, but what are your thoughts about things like that?
Yeah, so I think so there are a lot of keto products out there on the market now. When it comes to things like keto ice cream, keto snacks and things, I typically encourage them to be used in moderation, particularly for individuals who are following a low carbohydrate meal plan. So the keto products that you find on the market, a lot of the times they utilize the concept of net carbohydrates. So they're not necessarily low in carbohydrates, they are just low in the digestible carbohydrates. So utilizing a lot of these keto products can quickly add up in terms of total carbohydrates for the day. In addition, a high consumption of sugary, of these desserts and alternatives can sometimes shift away from the core principle of the low carbohydrate meal plan, which is to make sure that they're getting a lot of these nutrients from the three principles of creating that balanced meal. So including the quality protein sources, non-starchy vegetables, and sources of healthy fats. So definitely those products can be used here and there, but I would caution from having a meal plan that is highly processed or high in consumption of these products.
Thanks for that, Rena. And Dr. Gazda also added in the chat that, your point, of course, using it in moderation and that frequently, patients still can also use coconut flour or almond flour to make like cookies and cupcakes. So that's another good option. And maybe we can add something like that to our slide. And from a previous question that you'd asked about culture, like what cultures and food patterns do we want to try to address? We got a response in the chat that I've spoken to several patients of Asian and Hispanic backgrounds and would appreciate materials like specifically addressing that. We have a couple other questions in the chat that we'll come back to in just a minute after we get through these other pre-submitted ones, just a couple ones, and then I will come back to the ones that are there. So the next question was about ADA recommendations and proteins, and this first question ties in very closely to the next one, so I'm not sure if you addressed them all in one on the next slide, but what are the recommendations about low-carb diets from the ADA?
Yeah, so it is important to recognize that, or to acknowledge that, once again, there are some differences in the definition of low carbohydrate meal plans. However, the most widely used definition for low carb, very low carb, are based on the slide that I had shown prior. The ADA also has released their recommendations for the low carbohydrate and very low carbohydrate meal plans. So as we continue to sort of work towards, analyzing more of the literature that is coming out and the data that is coming out, we're hoping to really come out with a standardized consensus on the carbohydrate allotment for these low carb meal plans.
And what are the recommendations for protein intake, and does it vary with decreased renal function? Do you calculate protein recommendations based on lean body weight?
Yeah, so that's a really great question, and that this is also an area of growing research. And as we, sort of dive in and continue to learn more and more about the adequate the protein recommendations, I think there will be we will continue to see changes in the recommendations. However, many low carbohydrate or keto experts typically do recommend a protein intake anywhere between 1.2 to 2 grams per kilogram of reference body weight. However, so this range of protein intake has been shown to help to preserve muscle mass and provide that satiety to meals. However, there are many practitioners who go a little bit lower than that as well. So anywhere between 1 to 1.2 gram per kilogram as well. The current research suggests that, focusing in on at least 20 to 25 grams of protein at each meal, assuming 3 meals a day, that amount of protein can adequately provide satiety and also help to preserve and stimulate protein synthesis, muscle protein synthesis. Also, the amount of protein can differ from individual to individual based on their age, their activity level, etc. So the question of how much protein is enough protein is really nuanced and individualized. So I think starting out with, figuring out what is their normal protein intake, and understanding that the low carb meal plans, really the most important thing is to make sure that they're staying within their carbohydrate goals and replacing their carbohydrate intake with healthy sources of fats and making sure that they are getting in adequate or enough protein to help them feel full and satiated, together with a combination of non-starchy vegetables as well.
And I know we do have one question left, but I thought this tied in nicely with one in the chat about what about vegetarians? It has implications, of course, overall with low carb diet, and then I think specific to this protein question. So could you speak a little bit to vegetarians and low carb diets?
Yeah, so the low carbohydrate meal plans can be adapted for many different types of dietary patterns or dietary restrictions. So even on a vegetarian eating meal plan, an individual can can follow a lower carbohydrate meal plan. Albeit it might be a little bit more difficult because a lot of those protein sources on a vegetarian meal plan are often from legumes, which are starchier in nature. However, there are sources that are mostly that are lower in carbohydrates. For example, soy products like tofu and tempeh. I have some individuals who really enjoy using some protein supplements to help them throughout the day, whether that's to supplement a meal or to have as a snack between their meals. Depending on whether they were lacto-ovo vegetarian or pescatarian, they may be able to incorporate some eggs into their meal plan or some dairy products into their meal plan, which will also add to their protein intake. So it is definitely a little bit more challenging in terms of customizing their meal plan, but it is absolutely doable on a vegetarian diet as well.
Perfect. A couple of follow-ups on that. Can you please explain what comes under 15 GM carbs and 25 GM protein?
I'm sorry, could you repeat that question again?
Could you please explain what comes under 15 grams carbohydrates and 25 grams protein? And Dr. Ivankar, if you want to provide any additional context on that, please feel free to unmute and go ahead and do so.
Oh, okay. So if I understand correctly, are you referring to Dr. Ivankar? Are you referring to foods that have less than 15 grams of carbohydrates?
No. What I'm trying to find out is what comes under 50, like, when you're going to explain to the patient, okay, this is 15 grams of carbohydrates. This is 25 grams of protein. How do you visualize to the patient and explain to them that, okay, this is 15 and this is, it's easy for us to say, oh, this is 15 grams of carbs, but for the patient to recognize it, it's, how do they count it?
I see. Okay, I see what you're asking. That's a really great question.
Thank you.
I think that's a really important educational tool that we definitely need to have as to provide, or needs to exist for our patients and providers. So generally in the diabetes education world, we have what's called carbohydrate counting. So we already have established or existing materials based on the different types of carbohydrates and what equates to 15 grams, which is typically referred to as 1 carb count. So sort of speaking from just providing some examples here, but when it comes to things like starchy vegetables, generally a half a cup of beans or legumes is considered 15 grams of carbohydrates. A half a cup of potatoes or corn is also 15 grams of carbohydrates. So if it would be helpful, we can definitely provide a carb counting list from complex carbohydrates that we typically recommend on a low carbohydrate meal plan. Would that be helpful to have? We are actually also
I think
the
a
process
visual
of creating this too.
A visual would be better for a patient, or like, you know.
Okay, right. So like a handout with just visualization, not only just numbers and cup measurements. Okay, that's really great.
Yeah, means otherwise we give them the booklets. They hardly read the booklets because.
Right. Yeah. Similarly, we're hoping to create something very along those lines when it comes to protein intake too. So it's hard for individuals to sort of visualize what is 25 grams of protein. But generally in my practice, I use the concept of the palm method. So generally 3.5 ounces is about the size of your palm, and many of you might be familiar with this already, but the size of your palm and the thickness of a deck of cards is generally equal to about 3.5 ounces of an animal protein source like chicken, beef, pork, fish, etc. And generally that provides anywhere between 22 to 28 grams of protein. So there are slight variations, but that's just a general rule of thumb that I use when counseling on protein amounts.
Great. One other one related to the vegetarian piece. Any specific advice around vegan diets, Rena?
Yeah, good question. So vegan diets, definitely. I haven't counseled too many patients on the vegan low carbohydrate meal plan. However, once again, I do believe it is possible. So it's going to be more challenging on a vegan meal plan because it's restricted in most of the animal products. However, utilizing plant-based protein sources from soy-based products, tofu, tempeh, protein supplementation, which is oftentimes would be recommended to make sure that they're getting enough protein, as well as nuts and seeds can be incorporated. If they have a higher carbohydrate goal, they may be able to incorporate some sources of those complex carbohydrates in addition to their plant-based protein sources like beans and legumes, up to the point where they reach their carbohydrate limit. So that could be another way for them to get some additional protein sources in with the inclusion of lentils, beans, and other legumes.
Okay, great. Thank you so much. I know there's more questions in the chat. Didn't know, Rena, if you had a specific response different from your one about the ADA recommendations in general for this second question, which was similar. If you encompassed it in the first one, great. If you had anything you wanted to add, just wanted to give you that opportunity before moving on to the other chat questions.
Yeah, so I think, kind of going off of what I had mentioned earlier, it's going to be important to acknowledge that there are still some variations in the definition of low carbohydrate meal plans. The ADA has released a new booklet. The link is in the slides where they also discuss the low carbohydrate and very low carbohydrate meal plans and their approach to the carbohydrate allotment. However, we are continuing to do research and find that consensus towards having a standardized approach to the carbohydrate goals for low carb and very low carbohydrate meal plans.
Okay. Great. That was all the pre-submitted ones. I will stop sharing and we'll just go with ones from the chat. So let me make sure I'm starting at the beginning. So there is a question, do you suggest any phone apps to assist patients in identifying carbs or logging daily carb intake to track changes?
Yeah, sorry, Jackie, can you repeat that one more time? Is that about tracking? Sorry, thank you.
Yeah, nice. Do you suggest any phone apps to assist patients in identifying carbs and or to log their daily carb intake to track changes?
Gotcha. Yes. So there are so many tracking apps nowadays. So utilizing a food tracking app is especially useful on a low carbohydrate meal plan because patients are really just able to keep track on a day-to-day basis to see where they are in their carbohydrates for the day. some recommendations or some of the suggestions that I typically make are MyFitnessPal is a great one, Carb Manager. There's also Carb Master, I believe, and Senza. There are many applications out there that are mostly free to use, and they have an easy interface. But I would say MyFitnessPal and Carb Manager are the two that I generally use most often.
Great, thanks so much, and thanks, Laria, for putting those in the chat. There's lots of great resources that have been dropped in the chat during this call. Thank you, Jessica, for sharing that one, and others who have added some things there too. Next question, can you address the follow-up needs for low-carb meal planning, ADA, standards of care, short-term dietary intervention using structured, very low-calorie diets may be prescribed carefully for selected individuals by trained practitioners in medical settings with close monitoring? I think that was given as an example of like what a recommendation is around the monitoring for low calorie diet. So what does that look like for low carb? What kind of monitoring and follow up would you recommend for patients?
Yeah, so in terms of, am I understanding correctly in terms of what follow up and what outcomes we're looking at, or? I think like, if I'm interpreting this correctly, and Jessica, let me know if I'm not, like, how often would you suggest checking in with the patients? Are there labs that you do? Is there anything in particular that you want to ensure is happening with the patient who goes on a low carb diet? Gotcha. Okay. Great question. So generally for patients who are following a low carbohydrate meal plan, we would recommend having close regular check-ins as much as possible with their healthcare provider. One of the outcomes that we typically look at is weight loss, but also, checking in on their hunger and their satiety. How's their energy levels? And then we also like to check their A1C, their hemoglobin A1C, their fasting blood sugar, fasting insulin are also good labs to draw. And I think that would be it in terms of useful labs to check. Great. Thank you so much. And in regards in general to these questions, we will type up the responses to them and begin a document that just has a reference guide where you can look up anything that's been discussed during these meetings and what the answers to them were. So don't worry if you're not taking notes or are unable to right now. So moving on, we had a question. We had a patient recently who inquired if protein plus noodles or grains are a healthier option than those of whole grains. What are your thoughts? Protein plus noodles. Yeah, that's a great question. I have actually never heard of Protein Plus as the brand. However, it sounds like this type of noodle is fortified with additional protein. And whether or not they're a healthier option than those of whole grains. It really comes down to, I think, what this product is made of. It sounds like if it's fortified with protein, I would first look at the nutrition label to see what are, how many grams of total carbohydrates there are, how many grams of dietary fiber is included. A higher fiber containing product is going to impact one's blood glucose or less. So that would, it says, okay, so it looks like it's fortified with lentils, chickpeas, and peas. At the end of the day, these are noodles and grains that have been processed. It's still going to be considered a processed food. I wouldn't necessarily call it as a healthier option than choosing whole grains. However, it can be useful to have that added benefit of protein that's found in the noodles. Therefore, I think both can be utilized as part of a well-balanced low carbohydrate meal plan, as long as these products fit in with their daily carbohydrate goals. All right, great. Next question, does a patient have to be in ketosis for this to work for them?
If so, how will they know when they've reached ketosis on their own?
So an individual will be in nutritional ketosis generally when they are following the very low carbohydrate meal plan. So a patient does not necessarily have to be following a very low carbohydrate meal plan to see the results, such as improvements in glycemic control, improvements in A1C, and weight loss. The changes may be more gradual and over a longer period of time. However, we do see improvements in metabolic panels and overall health in both the low carb, which is less than 130, and also the very low carb, which is synonymous with the ketogenic meal plan. So to know whether or not they have reached ketosis, there are a few different ways to measure ketone levels. You can use a blood ketone measurement. So as we had talked about earlier, generally 0.5 is the threshold. So for ketosis, so a patient that has 0.5 millimole per liter of the beta hydroxybutyrate in their blood, they're considered to be in nutritional ketosis. 0.5 to 3 is the optimal range, but anywhere between 0.5 to 5 is considered to be a safe zone for nutritional ketosis. There are also urine strips that you can use to check for ketones in the urine.
Perfect. Thanks, Rena. Next question. Are protein powders vegan?
No, not all protein powders are vegan. There are plant-based protein powders. Generally, those will be made with pea protein. However, you always check the nutrition label to see whether it is whey protein, pea protein, or another type of casein or any other type of protein powder.
Okay, great. Those are all of the questions from the chat, but please someone message me if I missed yours. I think I captured all of them. Please feel free to put any other questions you have in the chat, or if you want to unmute yourself and ask a question, if you have like a specific situation with the patient that you don't want to type out extensively, but would like to ask and bring up more complicated cases, please feel free to unmute and ask anything that you'd like to know. Someone asked if this is going to be recorded. It is, and we'll post it. If there is anything sensitive that we need to remove from the recording before we post it, we will. Mm-hmm.
Yeah, thank you all for all the questions that have been coming in. We're hoping to have this sort of, casual, open forum going forward. We can talk about specific cases, and we're also hoping to have a specific topic for each month going forward as well.
Yes, please fill out the survey that Rena had shared at the beginning and that Laria put in the chat. It asks like what future topics you want to see, what are challenges, and then what other comments you have, because this is our first time doing this. We want to make sure that we refine these sections to meet your needs. So in order to do that, we would like to know how you want us to support you. So let us know what else we can do. And if there aren't any other questions, we'll stay on a bit. We'll stay on for the last little bit. And if you don't have any other questions, feel free to drop off. If you want to hang back and ask something until 1, please feel free to. And thank you for joining. And we will get your learning community physician level requirement met if that applies to you for your attendance here too as well.
Thank you all for joining today. We hope to see you back for future sessions.
Yep, thank you all so much, and thank you, Rena. Mm-hmm.
Hi, are you guys still there?
Yep, we're still here.
Hi, this is Jessica Seward. How are you?
Doing good. How are you, Jessica?
Good. I didn't really want to chime in too much during the presentation. I just wanted to say that I really did enjoy your presentation, Rena, and
thank you.
I come from a very different philosophy as far as carbohydrate management. So I was really impressed with some of the ways that you presented things. So I just wanted to say I appreciated that.
Thank you.
I did wonder why on your slides you didn't include under your whole grains resources anything that was a gluten-based grain. Is there some thought that GF foods are not acceptable sources of carbs, or kind of what's your take on that?
Yeah, that's a great catch, Jessica. I actually did not mean to leave out the gluten-containing grains. So absolutely, gluten-containing grains, whole grains, can be incorporated. These are just some ideas that had just come to mind. So yes, any gluten-containing grain, including oats, steel-cut oats, can be incorporated as part of the complex carbohydrate choices.
You might want to update that slide just to not give a you know, thing. So just a little thought there.
Yeah, perfect. Thank you so much for pointing that out.
Yeah, thank you for that, Jessica. And we'll make sure, like when creating patient-facing materials, to keep that in mind too. Might be a good idea to preview them with this group before we disseminate them officially to the collaborative arena. It might be just interesting to hear people's thoughts.
Yeah, sounds good.
Well, thank you very much.
Yeah, so the thought process that I had with the whole grains there, Jessica, was that we wanted to encourage grains that are closest to the whole grain form. And so that's why I added, you know, we don't typically eat wheat as just the wheat itself. And similarly with oats, I think, you know, there are whole oats that are sold in the market, but I just, out of things that are more generally found in the grocery store in terms of like the whole grain itself, I had put the barley, the farro, the quinoa as well as being whole grains.
I get the rationale between the use of the ancient grains, and I think you're looking for ancient grains or unprocessed grains, something like that. But you know, in my estimation, a steel cut oat is pretty darn close, or you know, some of the other
agreed
grains. Yeah,
agreed. So. Yep, absolutely.
It's just that gluten-free is it's almost as big a craze as keto diets right now, you know, and I really try to find the balance between recommending something that's balanced, variety, and moderation, and isn't feeding into one of the current fads that is out there. So,
and yeah, that's a very valid point. And yes, I'm certainly not advocating for gluten-free if that is not indicated in their medical needs. So definitely we'll be updating that slide to be more inclusive of the gluten-containing grains.
Yeah.
All right.
We will go ahead and sign off. Thank you so much, everyone, for being here, and we will see you again next month and get those next sessions set up. Thanks.
Thank you all.